we're now live as of now. And then, if you want to press on the bottom bar, you see those 5 icons.
Yes.
If you press the middle one, which says present now.
Oh, amazing. Okay, yeah.
And then share PDF.
Jesus. Yeah, it's uploading. It's just taking a second to upload.
Yeah, it takes a while. And then we should just check that, Jessica, you're able to change the slides once it's been uploaded.
Should I try presenting mine, or?
Let's see if answers work, and then if not, then yeah, you can present yours.
Okay.
And it wasn't just...
About halfway there.
It's all the pictures.
So should I just, so will I be able to change them myself?
So that, hopefully, yes. If not, then we'll ask you to just present your own.
Okay.
Yeah, it's fiddly, so it needs to be a PDF rather than a PowerPoint that we upload.
Okay.
We'll just see.
And what's the turnout normally like?
So normally we get about 100-ish people. And then obviously that varies depending on how long the talk lasts. So Jessica, are you able to change these slides? No, I can't. I don't think you can. Okay, so
it's up to you. You can call out and I can change them for you, or if you'd rather change
it might be easier just for you to upload. Maybe do you want to send the PDF version to Jessica, or you can make your own PDF?
Would you mind sending it to me?
Yeah, that's no problem. I'll send it to you now.
If not, I'll just...
Yeah, just send it back.
So then once you got them, if you press the middle button on the bottom panel, present now, and then just share PDF, that should do it.
Okay.
And then I think Anse, you'll stay for the talk?
Yeah, I'll stay if there's any issues.
So yeah, I mean, I guess Anse can help answer questions as well on the chat.
Yeah.
Just to kind of speed things along. Otherwise, I think that there's nothing else really.
The press record button, does it do it automatically?
It does automatically.
Okay, no problem. And then just at the end, we'll hang up the call.
Yeah, you can just hang up.
No problem.
Yeah. I think the registrations we had for this one were 92 of last checking. So probably expecting a turnout of about 70.
Mm-hmm. And in the previous ones, have you just sent, the sending feedback form? Have you done that at the end, in the middle? Or?
So did you send the QR to?
Yeah, it's in the slides already. But
brilliant. So yeah, and then you can just send the form. So if you go to chat and then you press the feedback button, you can just send the form easily.
Yeah.
For making polls, if you have to make do you have any SBAs?
I do. I was just gonna ask them to put it in the chat.
Fine, it's up to you. They can either do a chat or you can make a poll.
Mm-hmm.
On the right where it says messages, if you press polls,
yeah,
and then create poll. You can do that, but you think is you have to make your own. You have to make a poll every single time.
Okay,
It's a bit long, but it's up to you. It depends on how you want to do it.
Do you think they'd actually put answers in the chat?
They do. But obviously you'll get more engagement with the poll.
Okay, fine. Let me see.
Yeah, it's probably speedier to do it by the chat. So it depends on how time pressured you are.
I could make polls as we go along if
Yeah, is that okay?
Yeah.
Fine. Also, are my slides shown?
Yeah, they're there. We can see it. Brilliant.
Okay.
Nice. So yeah, we'll wait for everyone to join then. You can get going.
Great.
I'll dip once you guys have started.
Sure.
And once we get to 7, Ants, will you be talking first? Or should I just start?
I think just start. Yeah. Just crack on.
Okay, fine.
Are you on radiology at the moment, Jess?
No, I'm on GP.
You're on GP.
Yeah. But yeah, because I'm currently in the middle of applying for stuff for specialty. So.
Oh, nice.
But yeah, I'm not doing surgery.
Yeah, I'm the same. Answer's a bit more surgeon.
Oh, really? What kind of surgery?
Well, I don't know what you're applying for. I'll judge my answer accordingly.
Yeah, no, I'm gonna try for radiology, but it's super competitive, so we'll see.
And the exam is proper hard, from what I've heard.
Yeah, it's the MSRA, but it's super competitive. Like last year, the ratio of applicants to places was 9-1. So like, I'm gonna treat it as like a trial run, and then take an F3 and then try again.
Cool. I think from now on it will be recorded as well. So, and it will stop recording automatically. All right. So no worries about that.
Great, thank you. Shall we start then?
Yeah, we can make a start for sure. Yeah.
Yeah. Fine. So, hi everyone. Thanks a lot for joining. My name's Jess. I'm an FY2 doctor at King's College Hospital in South London. Today, I've been asked to do a talk covering lower GI surgery, which is quite broad. So we'll see how much we can get through. I do also apologise about my voice. I am just recovering from the flu, so yeah, it's been quite hard on my throat. So hopefully you can still hear me. But if there's anything that I've not been clear about or any questions, then feel free to put it on the chat. And yeah, I think this is mostly aimed at final years, but if there's any younger years as well, then you're all welcome to listen along, and also any questions, please put it in the chat as well. So our aims for today is to understand the spectrum of causes for lower GI bleeding, and also be able to differentiate between the different causes of lower GI bleeding. We'll then look at some benign anal pathologies, and then also hopefully by the end we'll become more comfortable in recognizing and managing surgical emergencies. So a bit of anatomy first. So the large intestine starts at the ileocecal valve. So after that you have the ascending colon, which goes all the way up, and then you have the hepatic flexure, which is that kind of turning point. And then this then turns into the transverse colon. And at the end of this, you have the splenic flexure, which is the next turning point, which then goes down into the descending colon, after which you have the sigmoid, and then lastly, the rectum, which then opens up into the anus, the anal passage. As you can see here on the right, the image shows some teeny E. coli, which are muscle bands that contract lengthways, and these produce the haustra, which is the kind of bulges in the colon that you can see. And this is quite specific to the large intestine, so this is not something that you'd see in the small bowel. Embryologically, the large intestine is made up of the midgut and the hindgut. So up until 2/3 of the way along the transverse colon is all midgut, and then after that is hindgut. And this is important because it relates to the vasculature. So the superior mesenteric artery supplies all of the colon up until the 2/3 of the way along the transverse colon, after which the rest is supplied by the inferior mesenteric artery. So first a question. I'm not sure if Ant is able to make a poll for me. Oh, thank you. So a 25-year-old male presents with bright red bleeding that occurs post-defecation onto the paper and the pan. His bowel habit is otherwise normal. What is the most likely cause of his symptoms? So I'll just give you a few minutes to put down what you're thinking. Yeah, great. So most of you've gone for 3, which is hemorrhoids. So yeah, that's correct. So the essentially what you're thinking is when you see a question with bleeding is where is the blood? So blood that's in the pan or that's on the paper as you wipe. So the blood that's not mixed in with the stool tends to come from lower down the GI tract. So specifically, this might be caused by anal pathologies. So you're thinking fissures and hemorrhoids. Whereas if you see blood kind of mixed in with the stool or streaky blood in with the feces, then this tends to come up from slightly higher up in the tract. So just to rule out the other options, so with colorectal cancer, you would typically see an older patient. You might have other symptoms such as weight loss, anemia. We will come on to colorectal cancer later. With an anal fissure, which again could give you bright red bleeding, but the main difference is that fissures are painful. And that's kind of the big giveaway sign between fissures and hemorrhoids on the whole, is that fissures are normally painful and hemorrhoids tend to be painless. You then have diverticulitis, which would present with symptoms of an inflammatory process. Again, we'll come on to this, but you would typically see some fever, abdominal pain, maybe some guarding. And an anal fistula, which is obvious, is as the term says, is lower down, so it is in the anal canal or the anal passage, but typically wouldn't present with bleeding. So there are different causes for bleeding, lower GI bleeding. I've just summarised them briefly here. So as I said, hematoschizia is the fresh blood on the paper or on the pan, and the causes are in this box. So we've mentioned the hemorrhoids and the fissures. Diverticular disease could also present similarly, as can angiodysplasia, which is a very rare cause of bleeding compared to the others in the box, but is essentially a vascular deformity in the GI tract, which predisposes someone to bleeding. I've also got here a massive upper GI bleed, which, as you all know, would typically give melena, which is that black tarry stool. However, in a very large bleed, the blood can act as a laxative and therefore can cause rapid transit through the bowel and lead to actually bright red bleeding instead of the typical melena that you'd expect. And then you've got colitis, which is in the table above. So here you might be thinking about infective causes, such as Campylobacter or Salmonella, or you might be thinking about IBD. Typically, you see over Crohn's if it's very bloody. And in this case, you might see some extraintestinal manifestations in the patient, or here in the question summary might mention this. For colitis, you might also be thinking about ischemic causes. So, for example, ischemic colitis patients would have risk factors either of thrombosis or of an embolism. So patients with a risk factor of having an embolism in their GI tract might be patients in AF. And if you're thinking about potential thrombosis in an artery, then the patient might have risk factors such as high blood pressure, hyperlipidemia. As we mentioned, melena would typically be the black tarry stool, which is indicative of an upper GI bleed. Risk factors are NSAID use, smoking, alcohol. And with all patients with lower GI bleeding, it's always important to consider a malignancy, which we'll come on to shortly after. So the anatomy, when you describe the anus, you describe things as a clock. So that clock is based off the patient being in the lithotomy position. So this means that they're on their back with their legs splayed up. And 12 o'clock would be up, 6 o'clock would be down, 3 o'clock would be to the right, and 9 o'clock would be to the left. So when you think about the anal canal, there are two types of sphincter. You have the internal sphincter and then lower down the external sphincter. So the internal sphincter is formed by involuntary muscle, whereas the external sphincter is formed by voluntary muscle, and they're both important in maintaining continence. So hemorrhoids. So they are swollen veins that are actually a normal part of the anatomy of the lower rectum. And they're very important because they form a seal in the lower rectum, and without them, we would lose continence. We have 3 of these vascular cushions, and they occur at 3, 7, and 11 o'clock. So when we say someone has hemorrhoids, though, it does mean that they have a disease relating to hemorrhoids, not just the fact that they have hemorrhoids themselves, because that's just a normal part of our anatomy. So hemorrhoids can be internal or external, and this depends on where they originate. So internal hemorrhoids are higher up, so these originate above the dentate line, whereas external hemorrhoids originate below the dentate line. In terms of presentation, so hemorrhoids the internal ones specifically, can become engorged and prolapse down, or they can become thrombosed, and this is when they can cause pain. So it's not a typical presentation, as I said, because they do tend to cause painless bleeding, but just to be aware that thrombosed hemorrhoids can cause pain in patients. Otherwise, the typical presentation would be painless PR bleeding in the pan or on paper, and also itching. Risk factors for disease relating to hemorrhoids includes anything that increases your intra-abdominal pressure. So pregnancy, constipation, obesity, and heavy lifting. So in order to diagnose a patient as having hemorrhoids, you would want to do a PR exam. So this is to visualize the area. And this can quite easily help you diagnose external hemorrhoids, which are lower down anyway, or prolapsed internal hemorrhoids. However, it is harder to diagnose the internal hemorrhoids that have not prolapsed yet, as they are further within. So for those, you would want to perform proctoscopy, which is essentially this little image here. So it's using a proctoscope, which essentially looks like a speculum, and you insert that in through the back passage to visualize the internal hemorrhoids. So with management, we break them up into conservative, medical, and surgical. So firstly, looking at conservative management, so a sitz bath is something that we recommend to patients. So this is when you sit in warm water and it soothes the itching and helps the hemorrhoids also to retract back in if they've prolapsed out. And as well as that, to also increase your fiber intake in your diet, so you're less likely to become constipated. Moving on to medical management, so topical anesthetics such as Anusol are really important because they can relieve the itching symptoms. And as well as that, topical steroids are really important. And if the hemorrhoids are thrombosed, then you'd consider GTN as well. Looking at surgical management, which is, what we're here for, there's two main things that you could do for hemorrhoids. So one is to literally go in and cut them out, which would be a hemorrhoidectomy. Or you can do something called band ligation, which is where you put a band around the hemorrhoids and you tighten them up. So essentially they fall off or they stay there and they shrivel up. But the mainstay would be hemorrhoidectomy. So another question, I think you might find this a bit easier now. So a 36-year-old lady with a background of Crohn's disease presents with painful PR bleeding. Bleeding is bright red and tends to occur after defecation. What is the most likely cause for her bleeding? I'll just give you a moment to respond. Yeah, so we've got a mix of answers, but the majority of you have gone for an anal fissure. So here, where's the bleeding? So the bleeding is bright red and again tends to occur after defecation. So we can rule out the colorectal cancer and the diverticulitis. She doesn't really have symptoms of that here. The main giveaway here is a background of Crohn's disease because patients with Crohn's disease are susceptible to extraintestinal manifestations and also perianal disease, particularly ulcers and anal fissures. So that's the answer here, anal fissure. The other option is anal abscess, which again, patients with fistulas can get. So patients with Crohn's disease are also susceptible to anal fistulas, and anal fistulas increase your chance of having an abscess, but it wouldn't present with this bright red PR bleeding. But we'll come on to fistulas shortly. So anal fissures. So these are a tear in the anal canal, and they cause excruciatingly painful PR bleeding. It is mostly idiopathic, but there are other risk factors such as constipation and inflammatory bowel disease, but in particular Crohn's disease. So as I said, Crohn's disease can cause perianal disease such as skin tags, anal fissures, and anal ulcers. And this is something that differentiates it between Crohn's and ulcerative colitis. So diagnosis, again, we want to be able to see what's going on. So you would offer a PR exam. A big giveaway sign for patients with anal fissures are that they are in excruciating pain. So they really won't let you have a proper look because it is so painful for them. And if you were able to see it, though, you would mostly find them in the posterior midline, which is something I know comes up in SBAs, but that is the typical location for an anal fissure. If the patient cannot tolerate the examination due to the pain, then you can do something called an EUA, which is an examination under anaesthetic. So this means you're giving the patient some anaesthetic, and therefore you can visualize the area properly and then treat them there and then according to what you found in the examination. Now, the reason that the fissures are painful is that this part of the canal is ectoderm, and so the innervation is thematic, and that's why it's painful. Whereas if you go higher up, you wouldn't feel pain because it's not. You wouldn't feel the tear because it's not ectoderm. So, looking at management, conservative, again, increasing fibre intake. Medical management is topical GTN, which is a vasodilator and a muscle relaxant. So it should help the muscle relax instead of being all tight and cramped and painful. And also using a topical anesthetic. And Botox can also help relax the muscle and help with healing. Oh, sorry. The surgical procedure most often performed is a lateral internal sphincterotomy. So it's quite a mouthful, but all it is you go in and you cut the internal sphincter from the side, and this opens that area up. So you have a bigger wound. So instead of it being small and tearing and healing, it's kind of flatter and more open, and this allows it to heal better. But the main risk of this procedure is the risk of incontinence because you're dealing with the sphincters. And I think it's about 1 in 10 people will get this complication. So moving on to anal fistulas. So a fistula is an abnormal connection between two epithelial surfaces. So here the two surfaces are the rectum and the skin. But there are different types of fistulas. So you have, if we go from bottom up, you have the submucosal, which doesn't involve the muscles. It goes kind of beneath them. You have the intersphincteric, which goes in between the two sphincters. You then have the transsphincteric, which goes which is through the internal and the external sphincter. You have the suprasphincteric fistula, which goes above the internal and then up and around the external sphincter. And then you have the extrasphincteric, which goes well above both sphincters. So does anyone know the most common type of sphincter? Sorry, most common type of fistula? And if you do, if you can put it in the chat. The most common type of fistula. No worries if not. It's intersphincteric, so that's the most common type of fistula that we see. So I've just seen submucosal. Yeah, good try. It's the intersphincteric fistula, so it's the one that goes in between the two sphincters, the internal and the external sphincter. So how does it present? It actually doesn't present with PR bleeding. It would present as discharge. I just see more answers. I think there's a bit of a delay. But yeah, it would present as discharge rather than bleeding. So you'd see foul smelling fluid, which can become infected and can form an abscess. Risk factors include diabetes, HIV, so anything that can suppress your immune system, and also IBD, so specifically Crohn's disease. So in fact, anyone with recurrent fistulas would be investigated for Crohn's disease. So again, the diagnosis is having a look, first line. And the kind of scan that you'd want to do to track the fistula would be an MRI. So this is to see exactly the passage that the fistula is taking, and helps you classify what kind of fistula it is. Moving on to management, it tends to be surgical for anal fistulas. So the mainstay, if there is an abscess, would be incision and drainage. So this is where you go in, you cut it open, drain the pus, and you leave it open, pack it up with Aquacel and put a dressing over it to allow the area to heal slowly. So that's incision and drainage if there's an abscess. Otherwise, you would either use a seton or perform a fistulotomy. So a seton essentially is a piece of thread. So all you do is thread it through the fistula, tie a knot. So you've made a little loop, but you don't tie it too tight. So there's a bit of tension, leaving the tract open, which allows it to drain freely. And eventually the amount of tension that you've got in the strings pulls the two surfaces together, leaving scar tissue, and pulls it closer and closer and heals the fistula. If you ever get a chance to see this, it is really cool. So yeah, that's the seton. Or otherwise, what they could perform would be a fistulotomy, and this is where you cut the tissue between the internal and external sphincters. And therefore, because you're cutting quite a lot of tissue out, it's more useful for the superficial sphincters, so like the submucosal and the intersphincteric fistulas. This procedure is contraindicated in Crohn's due to the inflammation, and also for any sphincters have any fistula, having a high tract, such as the extrasphincteric fistula. So it's more used for the ones that are more superficial, the more superficial fistulas. So another question now. I'm not sure if we've got a poll for this one, but I'll read it out. Oh, great, thank you. So a 70-year-old lady is admitted with a history of passing brown-coloured urine and abdominal distension. Clinically, she has signs of large bowel obstruction and is most tender in the left iliac fossa. What is the most appropriate investigation? So I'll just give you some time to think about this one. Okay, great. So most of you have gone for the CT abdomen and pelvis, which is the right answer. So this question's a bit trickier. It's got two parts to it. So you first need to understand the diagnosis and then know kind of the gold standard of investigating for that diagnosis. So this lady is in large bowel obstruction, and one of the causes for large bowel obstruction is diverticulitis, and this would go with the presentation of her being tender in her left iliac fossa. She also has this history of brown-coloured urine, and what the question is alluding to is that she's essentially got fecal urea, which is a consequence of diverticulitis, which we'll cover in detail. And so because this lady's got diverticulitis causing the obstruction, the main investigation would be a CT-AP, which is important for people in bowel obstruction, firstly, and also to investigate for where the stricture is that's causing the obstruction. So just going through the other answers, a cystogram is essentially a procedure to look at the bladder better. The ultrasound KUB would just see the kidneys, ureter, and bladder. A barium enema allows you to highlight the large bowel using barium liquid, which is passed through the back passage. It is really important in diagnosing IBD. And a flexi-sig is using a sigmoidoscope, which is like the proctoscope that we mentioned, but this looks at your rectum and your lower colon. Before we move on to diverticular disease, I've just got here the QR code. It would be really, really helpful if you guys could scan it and give us some feedback, just so we know if we're giving you content that's useful, and also it's just really helpful for us as well, for all the speakers, for our portfolios as well, to to see if we're giving you the right content and pitching it at the right level. So if you guys would give us some feedback, that would be really helpful. I think we'll paste the link to it if your QR code isn't working at the end, so don't worry if it's not working. So looking into diverticular disease, so the muscle layers in the colon are actually in a mesh. So this leaves kind of little pockets of weakness in the inner layer, which can then poke out, causing these little bubbles that you can see. And one of these bubbles is called a diverticulum. So that's essentially a single outpouching. So diverticulosis is having these outpouchings. It's this herniation of the mucosa and the submucosa through the muscularis. Diverticular disease is a state caused by symptoms pertaining to the colonic diverticulae. So it's having symptoms as a result of these diverticulae. And then diverticulitis is inflammation of a diverticulum, and it's the cause for any acute presentations. So risk factors for diverticular disease include having a low fiber diet, older age, decreased physical activity, obesity, smoking, and also alcohol. So diverticular disease is a spectrum. So as we said, the diverticulosis itself is asymptomatic. So that's just having these diverticular. They don't cause symptoms. But what does is the diverticulitis. So anything with itis means inflammation. So here you've got inflammation of the diverticulae, which are the little outpouchings because of the weakness in the mesh. So it causes symptoms such as left lower quadrant pain, fever, PR bleeding, and also can give you an abdominal mass if there's an abscess. And this is uncomplicated diverticulitis. Complicated diverticulitis means that there's a resulting consequence of the diverticulitis. So this could mean that the bowel wall has perforated. So this means that air or fluid or fecal material has come through the bowel wall and is in the peritoneum, causing peritonitis, which gives you symptoms such as guarding. The patient could be in shock, and also rigidity. Another consequence of diverticulitis is a fistula. So again, it's an abnormal connection, but here it involves the bowel and different other anatomical areas. So between the bowel and the bladder could lead to pneumaturia or fecal uria, which is air in the urine, or stools in the urine, which is the brown discharge from the previous question. It can also lead to a fistula between the bowel and the vagina in females, causing feculent PV discharge, and could also lead to a bowel to skin fistula. So as we said, common complications include the fistula, perforation, sepsis, but also obstruction, which is what this patient was in. It can lead to large bowel obstruction, because if you're having this inflammation, it can lead to a stricture, which means not all of the bowel is expanding like it should be, and you can get episodes of obstruction, and we'll go through the symptoms of that later. So in terms of investigations, if we go bedside bloods, imaging and any special tests. So anyone coming to ED will get an ECG, a urine dip, and in females, they'll get a pregnancy test as well. And if they have any PR bleeding, you'd offer a PR exam. You'd want to do bloods, so your full panel of RBC, FBC, USANEs, LFTs, CRP. You'd also do a clotting and a group and save. Now, this is really important because for any patients for which there's a chance that they could go into theatre, you'd want to know their clotting profile and make sure they can actually go into theatre. And a group and save, so we know their blood group as well. In terms of imaging, the diagnostic imaging for any patient with you're querying diverticulitis for is a CTAP, and you have a low threshold for this because a CTAP is really important to see if there's a perforation, an abscess, how big it is, and it is the diagnostic investigation. But if you're querying perforation, then you might want to do an erect chest X-ray. So this is where you get the patient to sit up for at least a minute before doing the imaging. And if they have a perforation, any gas leakage into the abdomen has time to rise up, just so it's under the diaphragm, so you could see it on an erect chest X-ray. So in terms of management, we'll split it up into conservative, medical, surgical again. So conservative would be treating the symptoms. So nausea and vomiting, you'd want to give antiemetics. For pain, you'd go through your ladder, starting at, paracetamol, adding in an NSAID or codeine. Buscopan can be really important for colicky abdominal pain. And for patients, when you're discharging them, you'd want to give them lifestyle advice. So this includes increasing fiber, increasing exercise, stopping smoking, reducing alcohol intake, improving their hydration, and also esophageal husk, which is essentially just a type of fiber that patients can take in tablet form. So medically, if the patient is a bit more unwell, if they're septic, you'd obviously do the sepsis 6. In terms of antibiotics, you'd consult your local guidance on that. In my trust, for uncomplicated diverticulitis, we were giving oral comoxiclav, and for complicated diverticulitis, IV comoxiclav. Interventional radiology are also really important for patients with diverticulitis. They can do really cool things such as draining any abscesses and coiling bleeds as well. So you'll find that if you have a surgical job, you actually do liaise with them a lot in helping managing your patients. And then for surgery, this can be emergency or elective surgery. So elective surgery would be if the patient has had frequent flares of diverticulitis. So if they've had frequent flares, or if there's been a previous episode of complicated diverticulitis, and this operation would involve removing the section of bowel that has the diverticula. And that would be something that you would plan in advance, so it would be elective. But most of the times when you're thinking about someone having surgery during an acute flare in the hospital, is because they've perforated. So the emergency operation you would perform is a Hartmann's procedure. So this is where you cut out the sigmoid colon. And we say sigmoid because this is normally the part of the colon that has perforated. So you remove the sigmoid and then you use the proximal loop of bowel to make a stoma. So you bring it out and you make an end colostomy. So Hartmann's is essentially a sigmoidectomy. So you're removing the sigmoid and you're bringing the proximal loop out to form a proximal end colostomy. And that would be the emergency surgery. We'd also follow up patients with an episode of diverticulitis in 6 to 8 weeks with a colonoscopy to also have a look at the bowel and visualize it and to rule out any malignancy as well. So just something to be aware of. So moving on to large bowel obstruction. So this is an important general surgical emergency, and this occurs due to a mechanical or functional obstruction of the large intestine. So this prevents the normal passage of bowel content. In terms of symptoms, it normally presents with colicky abdominal pain, bloating or abdominal distension, vomiting, which tends to be a late feature of large bowel obstruction. So it tends to appear later than in small bowel obstruction, just purely because it's lower down. And also absolute constipation, which means that you're not passing stool or flatus. In terms of signs that you might find on examination, they might have generalized abdominal tenderness, and also tinkling bowel sounds might be heard on auscultation. In terms of the causes, the main cause for large bowel obstruction is colorectal cancer, but you might also find that they have a stricture. This could be secondary to diverticulitis, as we said before, or due to inflammatory bowel disease, or it could be due to a volvulus. So a volvulus is essentially torsion of the colon around its mesentery, and this results in compromised blood flow and can lead to obstruction. So there are two kind of weak points in the bowel that tend to tort in that way, and this is the sigmoid and the cecum. I've got a little table here just about the differences. So if the sigmoid volvulus is normally seen in older patients with chronic constipation, or those with neuropsychiatric conditions, cecal volvulus is a lot less common than sigmoid, and is seen in patients with adhesions and also pregnant patients as well. So when we're thinking about risk factors for large bowel obstruction, they would include the risk factors, for example, for colorectal cancer and for volvulus as well. So can anyone tell me what this abdominal X-ray shows? So what sign this is and also what this sign indicates? Yeah, exactly. So this is the coffee bean sign, which you can hopefully see here, which is a sign of sigmoid volvulus. So whenever you're doing an abdominal X-ray for patients with that you're querying large bowel obstruction for, this is something to be aware of. The other rule that's really important for patients with bowel obstruction is the 369 rule. Does anyone know what that is? It's a bit more difficult to explain via message, but if anyone knows what it is and can give it a go. So it's essentially the upper limit for the normal diameter of the bowel. Yeah, exactly. So it's accepted that the upper limit for the normal diameter of the small bowel is 3 centimeters. For the colon is 6 centimeters, and then for the cecum is 9 centimeters. So that's a 369 rule. So anything over that, then you'd be concerned about an obstruction. So looking at investigations, again, bloods wise, you would do the full panel, the FBC using these LFTs, CRP, clotting, group and save, and then also VBG is important because this will give you a value for your lactate, which is really important in patients that you're worried about if they're going into shock or not. In terms of imaging, you would first line want to get an abdominal X-ray. And as we said, you might see distended bowel loops, or you might see a volvulus like in the image before. The gold standard, however, for imaging is a CT abdomen and pelvis. So that's what you can see here. So that's the abdominal X-ray on the left, and then that's the CT on the right, which will clearly show distended bowel loops and can also show exactly where the point of obstruction is. If you're worried about perforation again, then you would perform the erect chest X-ray. So in terms of management, you're always told in med school and in kind of all these revision question banks to do drip and suck, which in reality is what you would do. So you'd make the patient nil by mouth, so stop them from eating, give them IV fluids, and put an NG tube in. However, the caveat of this in large bowel obstruction is that in patients with an obstructed colon, if the ileocecal valve is working and patent, so this is the valve that separates the ileum and the cecum, the ileus and the cecum, then the valve will stop decompression from the colon into the small bowel. So what this means is there's increased pressure in the colon due to the obstruction, but the valve will stop it from moving into the small bowel. So if this valve is working, then the pressure of the colon is really high, and that can lead to an increased risk of perforation. But what it means in terms of management is that if you put an NG tube in, it won't actually be of that much help because the obstruction is only in the colon, so it's quite low down, and the NG tube obviously doesn't go down that far. But if the valve is not patent and the colon and all its contents can decompress into the small bowel, then the NG tube would be of benefit in decompressing the small bowel, if that makes sense. So that's just the practicalities. But in exams, you would always say drip and suck, which is IV fluids and NG tube for decompression. But just something to be aware of if you do a surgical job, of why NG tube isn't always that useful for large bowel obstructed patients. The other aspects of management would be analgesia, because they're in a lot of pain, antiemetics, and also IV antibiotics due to the risk of infection and perforation. In terms of the definitive cause, this depends on the definitive treatment. This depends on the cause. So if it's colon cancer, just going through the table, if it's perforated, then you do a Hartmann's procedure, which we'll come on to, or else we might just stent the colon. So this allows the bowel contents to move around the mass. For rectal cancer, we would do a defunctioning colostomy. For diverticulitis, we'd be looking at a Hartmann's, again, if it's perforated. For a sigmoid volvulus, we would use a rigid sigmoidoscope to kind of detort the bowel. For cecal volvulus, we would look into doing a right hemicolectomy. And for anything unclear, then you'd be looking at an exploratory laparotomy for the patient. So our final part, which of the following may be used to monitor patients with colorectal cancer? Yeah, so in the interest of time, I'll just tell you, but most of you have gone for the right answer. So that's CEA. So just looking at the others quickly, CA125 might be raised in ovarian cancer. AFP would be looking at hepatocellular carcinoma. CA199 is seen to be raised in pancreatic cancer, typically. I always got told that the 9 looks like a pancreas, which is how I remember it now. And then CA153 is typically raised in breast cancer. And essentially CEA is a protein that is not detected usually, but maybe produced by the cells in colorectal cancer. So in terms of the features of colorectal cancer, this typically depends on if it's on the left side or the right side of the bowel. So left-sided tumours tend to present with an early obstructive picture, fresh red, bright red bleeding as they're further down the tract, tenesmus, which is a constant feeling of having to open your bowels but being unable to, constipation, which is actually a very early sign of left-sided cancer, colicky abdominal pain, which is the pain you get as the bowel wall contracts and tries to move the stools down, and also an abdominal mass if the tumour is large enough. So right-sided tumours, however, tend to present with anemia, especially cecal tumours, weight loss, and also diarrhea. And this is seen because it's further up the colon, so it typically presents with diarrhea as opposed to constipation. But the important thing here is that it could really present with either, which is why anyone with a change in bowel habit, whether it's diarrhea or constipation, should be investigated for colorectal cancer. So the risk factors can be inherited or modifiable. So inherited causes include genetic syndromes such as FAP, which is familial adenomatous polyposis, which is where the bowel has over 100 colonic adenomas. And these patients are actually surveyed from, I think, about 15. They get an annual sigmoidoscopy, just to ensure that none of the adenomas have transformed into a malignant carcinoma. And then also HNPCC, which is Lynch syndrome. And these patients are also offered a colonoscopy every year or so from the age of 25. You might also hear about Lynch syndrome because it's associated with endometrial cancer as well. The other thing I've not included here to be aware of is IBD. So patients with ulcerative colitis are also at an increased risk of colorectal cancer, more so than Crohn's disease. Family history is another important risk factor. So having one first-degree relative increases the risk threefold. And also certain ethnicities are at increased risk of colorectal cancer. In terms of the modifiable risk factors, so having a diet high in fat and cholesterol, specifically from animal sources, as well as a high alcohol intake and obesity. So in the UK, we have our national screening programme, which is done every 2 years from 60 to 74. And this is when patients are asked to give a sample of their stools. And this is analysed for fecal occult blood. So the test essentially uses antibodies that are specific to human hemoglobin to look for any blood in the stool that isn't visible, to the eye, essentially. So any test that shows occult blood in their stools is immediately eligible for a 2-week wait, according to NICE. And the other criteria I've got down here as well. So anyone 40 or over with unexplained weight loss and abdominal pain would be eligible. Anyone 50 or over with unexplained rectal bleeding, and anyone 60 or over with iron deficiency anemia or a change in bowel habit. So this is strictly for the 2-week wait, but anyone else that you were concerned about, then you might want to organise some tests, which we'll come on to in the next slide. So again, in terms of investigations, anyone, if they were coming through ED, would get the ECG, urine dip, pregnancy test for females, and also a PR. Bloods, as we said, the same as before. Tumor markers are not diagnostic. They have a really poor sensitivity and specificity for colorectal cancer, but it can be used for monitoring progression of colorectal cancer. So it wouldn't be used to diagnose. So you definitely wouldn't do it in the first instance. Bone profile can be important as well, as you might see deranged calcium levels, and you might be worried about METs specifically. In terms of radiology, so if the patient is presenting in ED and they're obstructed and you're worried about colorectal cancer, then you would go through what we said before with an abdominal X-ray and a CT abdomen pelvis to look at what the obstruction is. However, in the non-acute setting, the gold standard for diagnosis is a colonoscopy. So you can clearly visualize the bowel and take samples for biopsy. If a patient is not suitable for colonoscopy, then you would want to do a CT colonography, which essentially, again, images the bowel, but using CT instead. So this might be more suitable for patients who are frail and for whom an invasive colonoscopy wouldn't be ideal. And if they are found to have colorectal cancer, you'd kind of move on to staging as well. And in that case, you'd be thinking about a chest, abdomen, pelvis CT to look for any distant METs. So management, this can be elective or emergency. Again. So in the elective setting, we can either do a laparotomy or a laparoscopy. And we can either do a primary anastomosis or use a defunctioning stoma. So primary anastomosis essentially means you're connecting the two ends of bowel. So you remove the cancer, the mass, and then with the two ends of bowel, you are able to anastomose and rejoin them again and reintroduce a blood supply. Or you can do the defunctioning stoma, which means you bring out a part of the bowel, and this leaves the area that we've just removed the tumor from to rest and heal, and later we can perform an anastomosis. And that would be the defunctioning stoma. The exact management depends on the staging. So for colorectal cancer, we use the Duke staging, which is A, B, C, or D. So for Duke stages A and B, normally it would just involve a surgical management. So this is where the tumor is just in the mucosa for Duke stage A, or for Duke stage B, it's just invading the bowel wall, so still very locally confined. For Duke stage C, we would be looking at surgery, but also adjuvant or neoadjuvant chemotherapy. And this is where patients have lymph node metastasis. And for anyone in Duke stage D, this is where they've got distant metastasis. It's really a case-by-case discussion, but they might just be more suitable for chemotherapy or a stenting procedure rather than a resection. And you would also involve palliative care as necessary. In the emergency setting, you would, if the patient has perforated, and again, most likely if the sigmoid colon has perforated, then you would perform a Hartmann's, which is the sigmoidectomy and colostomy. Other parts of the bowel can perforate, although this is much less likely, and therefore for your exams you'd only really be asked about a Hartmann's procedure, and this is where you remove the sigmoid colon specifically. So looking at the surgeries for any tumours in the cecum, the ascending colon, or the proximal transverse colon, you would do a right hemicolectomy. Therefore, you would remove all this area in blue. And then you would do an ileum and colon anastomosis. For any tumours in the distal transverse colon or the descending colon, you would perform a left hemicolectomy, and then the anastomosis here would be colon to colon, so it'd be part of the sigmoid colon to the transverse colon. And then for any tumours in the sigmoid colon, you would perform a high anterior resection to remove the sigmoid and the rectum. And this is also the same procedure that you would perform for any high-lying rectal tumours. For any low-lying rectal tumours, you would perform, or any tumours in the anal verge, you would perform an APER, which is an abdominoperineal resection. And this involves removing the sigmoid, the rectum, and also the anus. So before we finish, I just have a quick slide on stomas. So I'll just quickly run through this. So a stoma is essentially a surgically created opening into an organ. So here is the bowel, and then which is brought out and then covered by some sort of pouch system that collects the output for disposal. So if a stoma is seen in the right iliac fossa and it's spouted, like this image on the left, you'd be thinking about an ileostomy. So the content of this is normally liquid, and so it's a lot more watery than in a colostomy. And this is why the stoma, is spouted, because the contents are a lot more bilious and watery, and this is a lot more irritant to the skin. Whereas if you see a stoma in the left iliac fossa, which is more flushed to the skin, this is more likely to be a colostomy. And the contents here are a lot more solid and resemble more like stool rather than what you see in the ileostomy. In terms of types of ileostomy and colostomy, they can either have one lumen or two. So for the ileostomy, if there's just one lumen, it would be an end ileostomy. And this might be created if the rest of the bowel's been removed, for example, in familial adenomatous polyposis. Or if there's two lumens, this is loop ileostomy, and this might be done to defunction as distal anastomosis. As we said before, for example, if a tumour has been removed and you want the area to heal slowly and to give the bowel some rest, then you might perform the loop ileostomy. With the colostomy, again, one or two lumens. One lumen would be the end colostomy, as you see in a Hartmann's. Or two lumens would be the loop colostomy, again, to defunction part of the bowel. For example, if there's been a resection due to obstruction or malignancy. So the formation of a stoma can lead to many complications. I've just got a few down here. So some of the common ones are bleeding, infection, necrosis, and also a high output stoma. So this is where a stoma produces more than 1,000 ml of output a day. And this is really important because it can lead to electrolyte imbalances. So in patients with a high output stoma, performing a Boten profile is really important to check their magnesium and their phosphate levels. Stoma complications also include bowel prolapse. This is where part of the bowel moves further out, or retraction when it pulls further in. Or also a parastomal hernia, which is where you've got this bulge of abdominal contents under or around the stoma. And this is really important if there are complications of having the hernia, such as obstruction as well. So just something to be aware of. And then other complications include skin excoriation, fistulae, stenosis, and also all the psychosexual issues around patients having this new collective system that they kind of need to manage and get used to as well. So I think that's the end. I hope after all this, I know it's been quite quick, but I hope I've been clear in giving you a bit more of understanding in all the causes of lower GI bleeding, being able to differentiate between some important ones, also looking at benign anal pathologies, and also helping you get more comfortable with surgical emergencies. So yeah, thank you very much for attending, guys. If you've got any questions, then there's the email address on the slide here that you can email any questions to, or if you've not filled out the QR code or the feedback form yet, then please do so. And I think you get a certificate as well, which is really useful for your portfolios. But yeah, any questions, then feel free to put it on the chat. But if not, have a great evening. Thank you so much. Thank you, guys. And yeah, it says here certificate of attendance will be supplied once you've completed the form.
Thanks, Jess, for that. That was really good. Thank Mother for persevering with sore throat.
That's all right. I think it's actually getting quite annoying now, so I'm going to be quiet for the rest of the evening. I'm not going to say a word.
I think if we're happy, we can end it here.
Yeah, great. Thank you so much.
Thanks so much again. Thank you.
Thank you. Bye-bye.